Welcome to our newest episode of the Lebanese Physicians podcast. And today we will be discussing healthcare in conflict zones. And we will be especially talking about a recent paper about multi-drug resistant osteomyelitis in conflict zones. Our guests today are Dr. Anna Farra and Dr. Mohamad Khalife, who are both working at MSF currently. And in fact, Dr. Farra, actually, I know her very well. We worked together at the Rizal Hospital about 5 years ago. Welcome, Anna, and welcome, Mohammed, to the podcast.
Thank you.
Thank you.
So I'm going to start with Anna first. Anna, so when did you join MSF, and what do you do there currently?
Okay, so I actually joined MSF a very, very long time ago. In the early 2000s, I did my first mission and in Myanmar, which is Burma. I did one in 2001, that long ago. I was a young during my residency, and then I did another mission in 2007, also in Myanmar. Both were HIV projects, and then I started with MSF, or Doctors Without Borders, again in 2021, 2022. And I left the hospital in late 2022.
Right, and you were an infectious diseases physician at Rizal for a long time.
Yes. And before that, I was in Stockholm at Karolinska for a very long time also.
Right. And Mohammed, can you tell us about yourself a bit?
Yep, sure. So Mohamad Khalife, also MD. I'm actually one of Anna's students. I'm an infectious disease doctor. I've graduated like 6 years ago, I guess. And as an infectious disease, I trained actually in Lebanon. And I joined MSF around 5 years ago, I guess. I did 1 year of work in Beirut, then I joined MSF, and I never stopped, loving what I do. So that's why I keep doing it. Actually, Anna was the reason why I know about MSF. I was one of her students, and I still remember how she used to show us, the different pictures from her missions, different cases she used to see. So I really got interested in this path, doing more working in the humanitarian field, or working as a humanitarian worker as well. Yeah.
Yes.
So now I work with MSF mainly on antimicrobial resistance and implementation of antimicrobial stewardship programs in different parts of the world. You name it: Sub-Saharan Africa, Central Asia, some parts of Latin America, and the Middle East.
Yep.
Me and Anna, of course.
And that's
Yeah.
a good segue, I guess, into the recent articles you guys have published in, I think, the Open Forum for Infectious Diseases, right, which was Posttraumatic Pseudomonas, Aeruginosa, Osteomyelitis in Mosul and Gaza, which was a retrospective cohort study between 2018 and 2022. And just to touch on this paper, I think it's interesting, especially now with all the conflicts happening in the Middle East. Looks like you found that there's a lot of Can you discuss with us like the incidence of osteomyelitis post-trauma in these countries, and then what you found in terms of polymicrobial infections that you found?
Sure. So I was one of the main authors of this piece, and definitely there's a very important link between antimicrobial resistance, infection, and conflict in general. Conflict is a perfect conflict context. As a context, is a perfect scenario and the perfect recipe for chaos and for infections and for worse outcomes. So this has been our experience in not only Gaza and Mosul, but also in other countries. But since we're talking about this study, yes, in Gaza and Mosul we found quite a high incidence of post-traumatic osteomyelitis, because there is really lack of awareness about this topic. Many wounds get get forgotten. Access to a microbiology lab and microbiology sampling is quite scarce in many of the countries we serve. In Mosul, specifically in Iraq, it was a bit sometimes challenging getting access to microbiology. So MSF did ensure access to a microbiology lab when we started our intervention in Mosul post-war in 2018. And when we started, we have some antibiotics that we discovered are useless. So we discovered, for example, in Mosul, specifically Mosul, our staph aureus were around, it was very close to 99%. They were methicillin resistant, so they were super resistant, and also in gram-negative, we had so much resistance, reaching in the 50s to 60%. So we did have a lot of resistance. For Pseudomonas per se, I think the resistance was okay, but it was really striking seeing so much resistance in such a young population. So patients coming from the community sometimes, or visiting one hospital, they came with all kinds of very extremely drug resistant bacteria with antibiotics that were not available in Iraq.
In the country.
So MSF were supplying those antibiotics. Yeah. Anna, feel free, please, to add.
Yeah. So I was going to ask, my next question was, why? Because typically, I mean, you get like I assume that it's like amputations and potentially explosives and maybe bullet injuries that lead to this. So why is the incidence of osteomyelitis high? Is it because also like you don't have good surgical conditions in the war zones?
Yeah. In war, in war zones. So of course you have all the problems that come with a war zone, meaning you have poor infection prevention and control. You have to do surgery under poor circumstances. You also have surgeons that are not necessarily trained to doing trauma surgery. It is a special skill. And you cannot do primary closures. If you do that, you have more risk of infections. You need to do very basic things and keep wounds open. And this is something that is not necessarily in the mainstream of a normal surgeon. It's a specific skill. And so if you don't do a proper initial job, the risk of osteomyelitis increases. Also, there has been some studies, among other by Antoine Abou Fayyad, showing that probably also the fact that these heavy metals that comes with the bullet wounds, etc., they can also increase resistance. And then you have the post-trauma care, the changing the wounds, etc., where if you don't do it in a proper way, if you don't have the sterile conditions, if you don't have all of that, increases the risk for resistance. Plus, over-the-counter oral treatments can also increase this. And proximity, wounds people being moved from one place to the next, sitting next to each other, you can easily have contamination of the wounds. So it's, a combination of all of these factors.
Right, because you have a lot of like people in refugee situations living next to each other.
Absolutely. Yes.
Then no access maybe to proper wound care and maybe no access to proper antibiotics because medications are scarce.
And not only because medication are scarce, because you don't know what's in the wound, or you perhaps buy over-the-counter drugs where you will be perhaps under-treated or mistreated because you don't know what you're targeting blindly. So that is one reason also, but also the transport of wound patients, where soldiers might be put together in the same place, proximity to each other, and can easily get contaminated that way. Plus the healthcare personnel, when you have a lot of wounded patients, you don't have the time to do proper hand hygiene in between one patient to the next, so you contaminate one patient after the other. That is also possible scenarios.
And the issue is, so what happens? Because I assume also looks like your findings where you found a lot of multi-drug resistant Pseudomonas, MRSA, and some other multi-drug resistant organisms. So what if the antibiotics are not available? What's happening to these patients?
So we try to avoid usually this scenario. So we're always, trying to get, to get all the antibiotics that we can afford. Unfortunately, some of those antibiotics are too expensive for us to afford, like the very new molecules introduced
Not
into the
even very
market.
new, but
Yeah,
that
yeah. I
have
mean,
been
not
in the
very
market
new,
for a couple of years,
very new for us.
Yeah, but
Yeah,
things like
yeah,
cefiderocol that has
yeah,
been in the market for a
yeah,
few years is way
yeah,
out of reach for us, or even the
yeah,
combinations that are a little
yeah,
bit more advanced. If you would say ceftolozane, tazobactam, well, that's normal, but
yeah,
for settings like this, it is not.
yeah.
And and
It's
and,
not
and
possible.
MSF is a very strong advocate, to give access for these populations to these drugs that are too expensive. So
Yeah,
we do work, for instance, with Guard P, trying to get hold of those and pushing for the market to have it more affordable.
yeah. And in most cases, sometimes, when they are really extremely drug resistant, we try to check MICs, we try, different combination, hoping
Long
that will
infusions.
work, because sometimes, it's really tough to find an answer and to find the right treatment. So we try all sorts of combination,
Combination.
according to the availability and according to the MICs we get. And unfortunately, sometimes we have to go for really radical measures, that you've mentioned,
Amputation.
like amputations.
So basically, how are the outcomes of these? I mean, probably these patients have already been amputated somehow
Yeah.
or have had wounds. So how are the outcomes of these patients affected? Are they recovering from this, or is there a good percentage of them that are undergoing further
You mean
amputations?
the amputees?
Amputees,
Oh,
right?
yeah. I mean, so we do, part of the conclusion of our study, it's also proving, the effectiveness of our bundle of care, because in MSF for post-traumatic, osteomyelitis, we have a bundle of care that does not only include, the surgery or just the antibiotic. It includes everything. So from surgery, from antibiotic, physiotherapy, even mental health support. So we tackle, and even nutrition. So everything is kind of tackled. I'm sure I forgot some elements, but we tackle kind of every single, every single aspect of the disease, because the disease is
And the
actually
patient.
multifaceted,
Yeah.
So, and our results actually in the study, for example, really were comparable to experiences from high income countries. Although, we are, we did it in a very low resource settings, and we did, we did it, we try to do it as to be as economical as possible, providing our patient with the best care, and with while being very conscious about the cost as well. So our results were actually pretty good, and many of our patients recovers, and many of our patients are very grateful, for the treatments they're getting. Unfortunately, now the project has closed in Mosul, and Gaza, with the war situation, we are still there, but we are offering different type of care according to the needs now. Yeah.
Anna, did you want to add anything?
I wanted just to push for quality microbiology, because I think
Yeah.
without quality microbiology, it is quasi impossible to do proper osteomyelitis treatment. These are long treatments that take time. You also need dedicated surgeons that really know how to do a correct debridement and proper wound care. It's really going down to basics in a way, but quality microbiology is really key, and it is not easy to get in many settings. meaning you would get a
Yeah.
microbiology lab, but very often the quality is subpar, and the quality needs to be sustained, you know, both when it comes to the consumables, to the personnel, the way the culture is done, the interpretation. And also, I would like to do a call for the stewardship component, meaning that just having a microbiology lab and a surgeon is not enough, because interpreting those results takes an interface. It takes somebody that knows how to read them and knows how to dose and choose the right combinations.
Yeah.
Which
Yeah.
is
Indeed,
an
I can
infectious
add
disease
even on
physician
that if
and
you
a
want.
microbiologist, right?
Yeah.
Yes, yes, but because I'm saying that because I've been in emergency response for a while, and I've been to some of the places. I've been to Ukraine, for instance. I've been in different places where you have conflicts, and there's been discussion about, but we just put up a microbiology lab, but it's not that easy and it's not that simple. And it's better to have no microbiology than bad microbiology. If it's a message I want to
Yeah,
give, it's
because
that.
you are just wasting your resources. That's
Yeah.
also our conclusion after working with MSF. You know, you get those cultures that are really uninterpretable. You know, you cannot interpret them. You cannot really get a conclusion out of them, and they are really wrong. And sometimes they might take you, you know, to prescribe
Way.
the wrong medication, and even ruin. Yeah, I mean, it will ruin your result instead of helping you. So definitely a very important message, you know, highlighted by Anna. I 100% agree. And on the training part, just, you know, FYI as well, we do as MSF, what we have what we call MSF Academy. So I work actually partially for it, and Anna used to work for it as well for a while.
Yeah.
And it's like MSF University, and we have a course dedicated for antimicrobial resistance where we teach nurses and sometimes just health, any kind of healthcare workers how to become IPC experts. And we have also a dedicated course for antimicrobial stewardship, and those courses are offered to our locally hired staff, locally hired physicians for the antimicrobial stewardship part, where we train them on how to manage an antimicrobial stewardship program, how to interpret microbiology, how to understand microbiology. For many people living in high income setting, you know, microbiology is taken for granted. In many of the countries where we operate, it's a luxury, you know. So, and many of our doctors have never seen a microbiology result before in their life.
Right. Yes, it's important. So a lot of NGOs are on the ground in trauma situations, and it's important that quality care be provided and potentially quality microbiology be provided to be able to manage these patients correctly.
I mean, you need to differentiate between the acute situation and the osteomyelitis, because what we are discussing in this paper is the osteomyelitis phase.
Right.
So you are post conflict, post the hot, you know, the first line thing. In the emergency, the first line emergency, there is no time for microbiology. The important thing is to do the basic cleaning, the basic debridement, keep your wounds clean, take away whatever is necrotic, take away whatever is, and just do a swift and clean job. It is not the time for microbiology. The time for microbiology comes afterwards. So for the acute setting, it is more a good surgeon, a trauma surgeon, infection prevention and control. Do very basic things. Do not put any foreign material in your wound. Do not do internal fixations in the middle of a trauma surgery. This is, back to bases. First is do no harm.
Right. Got it.
And also stewardship, I would add, and proper prophylaxis. And
proper prophylaxis.
Not to give, because this is a common practice by many surgeons, leaving the patients on oral antibiotic for an extended period of time while there is no evidence that they really add anything. And our experience,
they actually do harm.
Yeah, exactly. So our experience as well from Gaza and Mosul, like many of those patients came to us while on antibiotics, and they have received antibiotic for many days, and while they were on antibiotics, they were developing multi-drug
Resistance.
resistant bacteria
Yeah.
infections.
Right. Yeah, because potentially it was more like they've been on the wrong antibiotic, or they've been on an underdose or subpar dose of an antibiotic that could have led to the resistance that they developed,
Or
I
a
guess.
completely unnecessary antibiotic.
Right, right. Because it leads to resistance. Correct.
Yes.
So now next I'm going to move to, because now we talked about Gaza and Mosul, but now there is a war in Lebanon at this point, which has been ongoing now for more than a month.
Correct.
And how do you think your findings will interpret, or will happen? And what findings will we have in Lebanon in terms of, let's say, chronic osteomyelitis, or how are treatments happening in Lebanon currently? Because if there's been a lot of trauma, and
Correct.
how's the medical system dealing with this? And are we expecting also episodes of post or multi-drug resistant osteomyelitis?
Okay, so I've been involved. I've been detached, as they say in MSF, meaning for a month I've been part of the emergency response team. I've not been doing my regular job, which is usually doing stewardship. So I was setting up what the Ministry of Health. So the problem but in Lebanon, as you know, a big part of our care is based on private care, on private hospitals. And in the private hospitals, I think, it's business as usual. We take care of our trauma patient. There is many hospitals with good quality microbiology. We are expecting the same resistance rates that we see the Middle East is basically, it's very similar. So we're probably going to see the same resistance rates when it comes to gram negatives. For gram positives, I think traditionally Lebanon has been a little bit lower than the other countries in the region, but it's bound to climb up quickly. Many of the wounded now, we as MSF have not seen at the moment because they've been absorbed by the private hospitals. So the AUB-MC have been taking a big number of those wounded patients. Actually, the bulk of the wounded has been taken up by the AUB-MC for some reason. So we're seeing much less of these wounded patients in the governmental hospitals. As soon as they get complicated, they go to the private hospitals, and the ministry is supposed to cover for it.
Yeah.
Yeah.
I can add a little bit. I think, honestly, I know that at the level of Ministry of Health in Lebanon, I mean, AMR is one of the priorities. I don't think we necessarily compare to other countries in the Middle East in terms of preparedness. Because I mean, we do have antibiotic guidelines. Ministry of Health has been pushing for a while for more and more antimicrobial stewardship programs. I know that also they were pushing for more IPC programs in many of our hospitals, and pushing for having IPC, supervisors or IPC focal points, like we call them in MSF, to be hired in most hospitals in Lebanon. And I think microbiology in Lebanon is quite it's not a rarity. Okay,
No,
so
and
for
the
example,
level is
Mosul,
quite good
yeah,
in many places.
exactly. In Mosul, at a certain point, I mean, hopefully now the situation is improving because the government as well is trying really to do its best to improve the the healthcare system in Iraq, in all of Iraq. They're doing very good job. So hopefully it will improve. But in Lebanon, we do have access to some good and quality microbiology lab. And I think antibiotic literacy in Lebanese curricula.
It's completely different.
Yeah.
You're on. We hear you.
Yeah. No.
Yeah.
Yeah.
Yeah,
Somebody
no,
was trying to call me.
Okay. No, I agree with Muhammad. We are in it. Also, to be noted that the Ministry of Health, ever since the October 7 war on Gaza, has been preparing. So there is already a trauma pathway plan. There is also already, contact with different NGOs. NGOs have been assigned to different hospitals. The Ministry of Health is actually very actively following up. So there is a preparedness that I think is very different than in the
Yeah,
other two case scenarios.
yeah, yeah, yeah.
Right.
So
I think, yeah, I've heard it from several people now that the Ministry of Public Health has been well prepared for this at this point, and I think the medical system in Lebanon too seems to be more resilient, I guess, and is better suited to deal with the situations, I guess, at this point.
Mm.
let's
I
hope it
mean,
stays.
Yeah.
yeah, I mean, within the governmental hospital network, it is a little bit different, but yes, I agree.
Exactly. I mean, it's different based on regions, but it looks like
Exactly.
a lot of the complex wounds are being absorbed by some of the more tertiary care centers who are actually still taking
Correct.
care of these patients, which is helping.
Correct.
So talking about this, I mean, given what's happening in Lebanon and Gaza and other places, what are the public health risks during conflicts, let's say, in terms because infectious diseases such as like incidence of lice, scabies, we forgot about other things like vaccine preventable diseases, such as I heard there was a recent case of cholera again in Lebanon recently, and I
Yeah,
think there
it
were
was
some
just
cases a
one.
while ago, one
Yeah,
case, yeah.
one
So what
case.
are the risks in these areas, and what are people need to watch for or to prevent when conflict happens?
I think you need, and Muhammad, you can interrupt me. So, as you know, there is quite a big proportion of displaced population now in Lebanon. We think that above 1 million people have been displaced. There are numbers that go up to 1.3 million people that have been displaced, from the south to the north. And a lot of people are being put in either schools or camps and that have not the capacity for, the sewage, the hygiene, toilets, if we're going to talk about it. So there's no capacity. This capacity is difficult to absorb this much people. So you will have problem when you have a lack of hygiene. Then you can imagine if you can't take your shower, if you can't, all of this will lead to these diseases that come with you can't conserve your food properly, etc. So you will have problem with gastroenteritis, diarrhea. You will have problems with uh, respiratory tract infections that go around because people are so close to each other. They don't have the right shelter. There's not the cold. The vaccination coverage will go. I mean, you have all of these that come, of course, and then you have scabies and lice, and scabies is a problem now in the displaced populations. You also have all the non-communicable diseases that is a problem. People that have to leave their medication behind, people that cannot take their medication properly, hypertension, diabetes, all of that, if you don't have your medication, it is a problem. You don't have your charts with you. You have not access to your regular doctor or to a doctor at all. All of these, play in.
Yeah. Yeah. I think wash, I think really we need to concentrate on everything related to wash,
Water
environmental,
and sanitation
water,
and
yeah, wash,
food,
exactly.
water,
Because
sanitation, the basics. I mean,
yeah,
really, it is the basics.
yeah,
A place to sleep, a place to eat, a place to, do
yeah,
clean, clean. So, and this
yeah,
is what is, I
yeah,
think, to provide the basics to avoid all the other problems.
yeah.
Right,
Especially
right.
that we are becoming kind of an endemic country for cholera because we're getting bouts, we're getting cases every now and then. It's not like
Yeah. But the
a few
water
years back.
source, I
Yeah,
know, but the water sources are being checked, and
yeah,
the Ministry of Health has a completely different
yeah, yeah,
awareness now
for sure.
than
Yeah,
it was before, and is able to immediately, because we've had this outbreak a couple of years ago, they
yeah,
can immediately go in and check the water. So there is a completely different
yeah.
response now.
I 100% agree. Yeah,
Right. So yes, it's important to maintain things, and not only like have clean supplies up front, but also maintain things down the road too, I guess.
Yes, it should be the other way
It should
around.
be the other way around.
And then my other
Did not
question is
hear.
also
No, we did not hear. Repeat,
Oh, you
please.
didn't hear me? Okay. No, I said it's important to maintain things and maintain the clean situations, not only like up front, but I think now we're going to have refugees for a while. So it's also important to maintain down the road and have the involvement of NGOs and the Ministry of Public Health at the same time in this.
And the Ministry of Public Health is actually organizing the response, is orchestrating the NGOs' response. So the NGOs have to declare where they're going to go, which shelter, what day, and so on. There is still no clear, I mean, there is still a problem with the charts, meaning patients that need follow-up, because the NGO will go from one place to the other. Follow-ups are and there is a collaboration with the NGOs with the primary healthcare centers. So the Ministry of Health has organized, clusters that refer to a certain PHCC. So, I mean, it's getting slowly organized, I think. And now we have to prepare for the upcoming winter.
Right, because the winter is going to be like cold situation, especially probably in the Bekaa Valley and some of the other mountain areas.
In spite of the climate change, yes.
Right.
Yeah.
What about vaccinations? I guess, are we making sure that people are up to date on their vaccinations while this is happening?
There is I'm not. There is no official campaign at the moment, but I think this is something that's going to need to come very soon.
Yeah, indeed. Yeah, I think that it's just it's a quite recent, a little it's an acute chronic war. So people were more focusing on like trauma and how to manage trauma. Yeah, but I mean, all of these topics will definitely come later, and I think it will be prioritized sooner or later, hopefully. Yeah.
That seems what you guys are telling me, and I'm gonna just I'm gonna interpret, and you can feel free to correct me if I'm wrong. But what you're saying is there's a huge role for NGOs in conflict zones, especially in Lebanon, let's say right now, and at the same time, looks like there's a huge role of like having the government or the Ministry of Public Health be the one distributing the resources according to needs, because that will also help make sure that the resources are being given correctly in the correct areas by the different NGOs that are involved.
Yeah,
I'll leave that to Anna. I know she has some points to add on this one.
Sorry, I missed the question.
Yes,
because
the question was, it seems like NGOs play major roles in conflict zones, but it's important that we have like the Ministry of Public Health or a higher place to manage resources.
So NGOs do play a role, but I do want to emphasize the very important role of the local hospitals. I mean, the local hospitals, be it in the south of Lebanon, they have worked hard, and some of the hospitals are still up and running. And I really want to, lift my hat or chapeau bas for all the doctors and healthcare personnel that risk their lives daily working in the hospitals in the south. Honestly, and I also want to flag out the targeting of healthcare personnel in the war on the war in Gaza and the war in Lebanon. Hospital or healthcare personnel have been specifically targeted, and this is not acceptable. Strongly condemning it. And also for you to know that NGOs, although they do a lot of work and they, supported local people, and local NGOs are also really doing a fantastic job, and we try to do our best to support them.
Yeah. And also to add, to just what you said, like, I mean, yes, NGOs are very helpful, but I don't, none of them can replace the coordinating role of the Ministry of Health. Ministry of Health has a very important role in coordinating all the activities and making sure that the resources are distributed evenly, because sometimes I think we go through scenarios where you know um uh you get, like, I don't know, let's say three a 20 ventilator in a hospital that has a capacity for 10 ICUs, for example, while you have rupture in very major medication. So it's really important, to coordinate all of those. And I think Anna
But it's not
had,
easy.
yeah.
This is not easy,
No,
and
for sure, yeah.
this is not easy for the Ministry of Health either.
Yeah.
No, I'm Mohamad is I don't know, maybe this is off the record, but then you'll have to cut the the podcast.
Yeah, I'm sorry, Anna. I've put you in
You're
the.
putting me. No, I've been involved in the Turkish hospital. I don't know if you know about the Turkish hospital in Saida. So the Turkish hospital in Saida is a hospital that was built after 2006. So it was donated by the Turkish government in 2010 in Saida. It was inaugurated, never opened. It's a 300-bed trauma surgery hospital. Beautiful hospital, completely equipped with ventilators, with surgical machine, everything, the works, never used. Now, almost 15 years later, this hospital is to be opened. So you can imagine. I've been involved in the opening. It took a month to open it. It's open now, but it still needs a lot of work. And there's a lot of NGOs involved in it, so it's a bit tricky, but it's open now.
It just opened during the conflict, is what you're saying.
Yeah.
Okay. Which is probably important because there's a need for more beds now, especially with hospitals in the south closing down.
This is what is the rationale behind opening it.
So I mean, what I hear from both of you is in Lebanon, looks like there's a coordinated role between the Ministry of Public Health, the local hospitals and local healthcare workers, and the NGOs to provide probably the most streamlined and safest healthcare possible to the refugees in this very difficult situation.
Yes, and it's not only the Ministry of Public Health; it's the Ministry of Health per se,
right?
And where the minister is honestly very involved and very active.
Right.
Yeah.
He's doing very hard work
in
this very difficult situation, and hopefully the situation will finish soon. So I'm going to ask you both, since you're on the ground right now, what can listeners do to help support and help with the situation that's ongoing on the ground right now? Because I know a lot of Lebanese are living outside the country, and a lot of them really want to help.
So,
yeah,
financial helping in any way possible is always a help. Okay, we're both MSF, so we're gonna say donate to MSF.
That's a conflict of interest.
Exactly. You asked the question,
Yeah. I mean, honestly, for me, not only MSF, like all,
serious, bigger
all
NGOs,
serious stakeholders really working on the ground, will eventually need financial support. So that's definitely, I think, the best way to help, because I've seen some campaigns, to send medications or random quantities of medications, random quantities of
not helpful,
items not necessarily needed, or not necessarily reflect what the people actually need. So I think it's better to really support the people, as you said, that working on the ground, who knows the situation and who have done official assessment in order to say like, yes, we need to work on this, we need to work on that, we need to in order to assess, to help and support our the people of Lebanon.
Yeah. So it is better to give money to a big, I know these big NGOs, but these big NGOs actually do the job on the ground and they have the means to do it. Instead of, just giving some medication or some clothes or some.
Right.
It is drier.
Yeah.
It is drier, but yeah.
Yeah, these big NGOs have had experience in a lot of conflict zones before, and potentially, like where the money is going, administrative fees versus fees on the ground that are being used. But I think one thing also the Ministry of Health did this time is they've sent actually a list to different embassies and stuff like that, a list of the medical supplies that they need. And they didn't ask people to send whatever they send. They just sent what is needed, and they're asking for help with that.
Yeah. Correct.
So thanks to both of you for being on the podcast, especially in this busy time for you both, I'm sure, with the situation on the ground currently. But I'm sure you both are doing great work at this point. And Anna, it was great connecting with you again.
Yes, absolutely. So nice.
Yeah, and Mohamad, it was nice meeting you.
Yeah, very nice meeting you.
Thank you for having us.
Thanks. Thank you.
All right.